I'm Sandro Galea. I have the privilege of serving as Dean of School of Public Health at WashU, and welcome to Public Health Ideas. These are conversations we're having to highlight work that's relevant to public health from faculty across WashU. And today I have the privilege of speaking with Professor Matt Kreuter. Professor Kreuter is the Kahn Family Professor of Public Health at the Washington University Brown School of Social Work, and we're going to be discussing his recent paper in the Journal of Public Health Management and Practice called Repeated Exposure to COVID-19 Misinformation, a longitudinal analysis of prevalence and predictors in a community sample. Matt, welcome.
Sandro, thanks. Good to be here.
So tell us a little bit, lead us up to this paper. What work had you done? What were you thinking about that actually led to this paper?
Yeah. First of all, let me just say that my amazing colleague Kim Johnson, and a faculty member at the Brown School, also was a part of this, and as was our doctoral student Olivia Wang. So this is kind of all of our
Wonderful.
Collective work. We, as you know, sort of public health is interested in exposures that have health consequences, positive or negative. And in public health, when we think about those exposures, we usually think about, you've been exposed to some toxin or maybe cigarette smoke over many years. But information is also an exposure, and misinformation is an exposure. And the way we've thought about misinformation in public health, I think, has been a little too simplistic. We think about it as a binary, like you were exposed or you were not exposed. And we sort of suspected that the reality was different than that people got different doses of exposure, that some people got exposed to misinformation over and over and over again, and we wanted to find out if that was the case. So we set up this study to see what proportion of people were getting multiple exposures to misinformation, in this case about COVID, and were there certain characteristics that defined people maybe at greater risk of being exposed multiple times to misinformation.
Define misinformation for us.
We think about misinformation as information that's shared, but it is inaccurate or false or maybe incomplete, and it doesn't necessarily have to be intentionally so. If it's intentionally so, if I'm giving you false information with an intent to deceive you, we think of that as disinformation. But for the purposes here, it was more broadly misinformation, just not accurate health information.
So before we talk about the study, tell us about iHeard, which is the platform on which the study is based.
So I'll take you back to January of 2020. So the COVID vaccines have just begun arriving in St. Louis. And I get a call from the Health Commission.
January 21.
January 2021, December 2020. Yes,
Yeah,
roughly a year into the pandemic. Thanks. And I get a call from the acting health director at the St. Louis County Department of Public Health, Spring Schmidt, and Spring says, our people on the front lines are hearing all of this stuff that they it seems crazy and they don't really believe it, but they're completely ill-prepared to address it. Is there anything we can do? And on that phone call, Spring and I concocted this idea of what we first thought of as kind of a surveillance system. We now think of it as listening infrastructure. But we wanted to engage the community every single week and find out what are they hearing. And once we knew what they were hearing, we would be able to determine if there were information threats that were inaccurate that we could be addressing, and then prepare responses, accurate responses to those false claims, and put them in the hands of practitioners on the front lines so that they would be better equipped to deal with it. So that's how iHeard started. What we've now been doing for 3.5 years, every single week, without missing once, we survey 200 St. Louisans, and now it's spread beyond St. Louis, but in St. Louis, we survey 200 St. Louisans, pushing a short 2 to 3 minute survey to their mobile phone. They have 48 hours to respond to it. Our response rates are 88 to 90% every week. And then we take that information, and within hours, we can identify what are the biggest information threats that are facing St. Louisans. And then we prepare responses to those. And those responses are sort of like press releases, we call them alerts, but also social media assets that can be easily shared. And we push those to 200 community partners so that they have them and can distribute them. And that's iHeard. And so the way iHeard relates to this study that we're talking about is that we have this panel of community members and we follow them week after week after week, which allows us to see what is repeat exposure, how many people are hearing the same thing, 1 week, and then again the next week, and so on.
So what was the key question in the study? What were we trying to answer?
I would say the main question was, how common is it? Like how much repeated exposure happens sort of naturally in a community? And then sort of a sub-question would be, are there any groups, subgroups that perhaps are exposed to misinformation more frequently than others?
So what did you find?
Great question. A lot, basically, a lot of repeat exposure. So for this analysis, we looked at 5 specific claims that were all about the COVID vaccines. And what we found was that as many as 40% of people heard an inaccurate claim in at least 3 different weeks. So we ask people, the way we measure this is, have you heard about X or Y or
Z? Can you give an example of a claim?
Yeah, sure. So one would be, we have booster shots are developed because the original vaccine doesn't work. Okay? And so we would, if someone heard that, we ask them, have you heard this claim in the last 7 days? And then 7 days later, we ask them again in the last 7 days. And so up to 40% of people heard these 3 different weeks. And up to 20%, think about this, 1 in 5 people heard about some of these claims 6 times. So this is not a binary exposure. This is a repeated exposure over time. And if public health is going to be, in the fight trying to combat misinformation, it's going to have to match that sort of sustained response.
Tell us the consequences of misinformation.
Yeah, so we actually use the term consequential to define what misinformation is worth pursuing and acting on. So I could tell viewers and listeners, Dr. Galea is wearing an orange blazer. And that's patently false, and anyone could see that, but there's not a lot of harm in that. But if I'm telling people that if you take a particular medication, it causes sterility, or you're going to lose your fertility, and on the basis of that, you decide to not take that medicine that you need, and there's a consequence that you suffer because of it, that's now consequential. So the sort of causal path that we're most concerned about is exposure to misinformation, belief in the misinformation, and then acting or not acting on the basis of that belief. So that's the pathway that is most threatening to public health and that we're trying to interrupt.
How does public health act? What do we do? We hear a lot about misinformation lately. So what are the right next steps?
Yeah, so in the scientific evidence, what we know most about is what we would think of as sort of debunking myths, which is very reactive. So someone says something and then we say, no, that's not true.
That's right.
And another approach that is sort of supported by evidence is what we would call pre-bunking or inoculation, which is I tell you, you might hear that X causes Y, but that's not right. So we're trying to prepare you to reject it. And those both work, but I think there are limitations there. They make certain assumptions and they're kind of reactive. I would say, as I think about what public health should do, first of all, communicating health information to the public is one of the 10 core functions of public health. That's not new. We're supposed to be doing that, and that's essential for public health to work. But every evaluation that I've ever seen suggests that most public health departments, certainly local public health departments, don't have the capacity to actually do that very well. And the same is true of community-based organizations. They don't have the capacity to do it very well. At the simplest level, it's pretty rare to find a local public health organization that has one person wholly devoted to public information and public communication, and let alone have that person be really trained and qualified to do it. Does that make sense? So here's what I want to kind of suggest to you. And you're a public health historian, so you appreciate this. We didn't always have school nurses, but kids were missing a lot of school because of infectious diseases, and so we put nurses in schools. We didn't always have restaurant inspection in public health, but after World War II, restaurants sort of, explode in popularity and use, and we want to protect the health and safety of the public, and so we make sure that those restaurants are safe. Here we are in 2025. in an information age where information of all sorts, accurate and inaccurate, is all around us all the time, maybe it's time that we need something like a health information, health knowledge core to really kind of modernize how public health responds to that. And I've got some ideas about what a health information core would do in public health.
That's so interesting. So what's next for your work?
So we are continuing to, in this space, we're continuing to work with iHeard. We've expanded now. We're adding 3 new states in the next 2 weeks. Actually, we've been training them, but they'll go live in just a couple of weeks. 1 in Mississippi, 1 in Georgia, 1 in North Carolina. So the spread of iHeard, where WashU is the coordinating center for all of those activities. And I feel like we've demonstrated pretty clearly that, we can set up community listening infrastructure. We can respond rapidly to what we learn from community members. The part we have to really figure out is how do we cover that last mile? How do we get information from the hands of community partners and local health departments out to communities? That's been the most inconsistent part of this. So that's what we're working on.
That's terrific. Thank you for the work you're doing. I look forward to talking more about it.
Great, thanks.
Thank you for being part of the conversation.